Coming on to two pips and a rip. Aripiprazole. It is a D2 receptor partial agonist, and this is the major differentiating pharmacological feature. This results in reduced EPS and hyperprolactinemia. It also has 5-HT1A partial agonist action, that is more potent than its 5-HT2A antagonistic action but less potent than its D2 binding affinity. It is effective in treatment schiz and mania and is approved for use in various child and adolescent groups including schizophrenia for age 13 and older, acute mania and mixed mania for age 10 and older, and autism related irritability in children aged 6 to 17. It lacks sedation as there is no M1 and H1 antagonistic properties, and like ziprasidone and lurasidone, there is little or no propensity for weight gain, dyslipidemia, elevation of fasting triglycerides, or insulin resistance. If switched to aripiprazole, there can be weight loss and lowering of fasting triglyceride levels. Maybe it lacks the ability to bind to that X receptor mentioned previously. It is approved as an augmenting agent to SSRIs and SNRIs in treatment-resistant major depressive disorders as well as bipolar depression. Explanation for this is its potent 5-HT1A antagonistic activity as well as 5-HT7 partial agonist activity. Partial agonist actions at both D2 and D3 receptors mean it acts more as an agonist than as an antagonist at D2 receptors at low doses, thus slightly boosting rather than blocking the hypothetically deficient dopamine neurotransmission. Too hot, that is, too much of an agonist, and thus can be activating in some patients, causing mild agitation as well as causing nausea and occasional vomiting. Or too cold, meaning that it is too much of an antagonist, causing akathisia in some patients, which can often be decreased by dose reduction or administering anticholinergics or benzodiazepines. An intramuscular dosage for short-term use is available, as are orally disintegrating tablets as well as liquid formulations.